Hello, everybody. Good evening and welcome to this new ESG webinar. Tonight, we are discussing of a very, very hot topic on EUS-guided intervention for bile duct drainage. And for this reason, we have had already a lot of registration, 870 registration at the moment. And why so many registration? Because this is really a hot topic, because in the last years, the technical development that happened in an endoscopy have given us the possibility, the chance to assess to the biliary tract from different sides with a very high level of technical and clinical efficacy, so high that today there is a huge debate, a discussion, if these new techniques could replace ERCP in the next future. I am Paolo Arcidiacono. I am HPB endoscopist and professor of gastroenterology in Vita Salute San Raffaele University. And I'm sharing this webinar together with two very, very super expert in this field. Dr. Roy van Wanrooij, who is a gastroenterologist, head of the endoscopy unit in AMC Amsterdam, the Netherlands, and Dr. Fabrice Caillol, who is gastroenterologist, head of the endoscopy unit at the Institut Polycalmette, Marseille, France. Before starting the talks of my two colleagues, I want to tell you that the argument is huge, is a very debated topic. So please don't be shy. You have the possibility to ask as many questions you want in the Q&A in box. So please don't be shy. Make a lot of questions, because Roy and Fabrice are here to answer all your questions. So Roy, it's a pleasure having you here tonight. You will be talking about EUS-guided choledochduodenstomy. Please.
Thank you, Paolo, and good evening, everyone. I'm excited to be part of this webinar and to talk about EUS-guided choledochduodenstomy, which is probably the easier of the two techniques that we discussed tonight, and for that reason probably being implemented in more centers around the world already. So these are my disclosures. So tonight I'd like to talk first about the technical part, how to do it, what can go wrong during and after the procedure, and then we go to the clinical part about when we should do it. So how to do it, the setting. I know there's much debate about if you should use fluoroscopy or not. Personally, I feel that you should. First of all, because we always place a coaxial stent through the lumps to prevent stent dysfunction. But also in case you get into trouble during a procedure when there is bile leakage and you need wires, you need contrast, you need fluoroscopy to save the procedure and the patient. In an ideal world, you also have deep sedation or general anesthesia so that the patient is calm and you can do your work. And you need an endoscopist that has adequate training in therapeutic EOS and ERCP. Okay, so the most important factor that will decide whether the stent will be placed successfully is probably the diameter of the common bile duct. So if the bile duct is over 2.5 centimeters, the procedure is quite straightforward. It's almost like a pseudocyst drainage. There is even some room for error. If the bile duct is in between 16 and 25 millimeters, the procedure is very feasible, but there is no room for mistakes anymore. And when the bile duct is less than 60 millimeters, it's becoming a very difficult procedure, and the adverse event rate is increasing rapidly. So how does that relate to real world? Well, unfortunately, it's not that good for this procedure, because if you look at the data of the bile duct diameter when the patients present with jaundice, it's only in about half the patients that the bile duct is sufficiently dilated. And if you consider the 12 millimeters as a cutoff, you see that 1/5 of the patients is not eligible for this technique, how we are using it currently. So there's still room for improvement. And why is that? Most of us are using the lumen-opposing metal stents for this procedure. And if you would look at the runway, as Kenneth Bindmüller, the inventor of the stents, calls it, if you look at the yellow line, that's the depth of the distal flange, but the runway of the stent is actually quite long, which means you have to push in the stent catheter quite a long way inside the bile duct to make sure that the distal flange deploys in the bile duct itself. So even for the smallest stent size, which is the 6x8 hot axis we have currently, you still need 20 millimeters of stent catheter to get inside. And then I just showed you that you can do it up to 12 millimeters. And that's because when you deploy the stents in a stepwise manner, you will actually pull back the stent from the catheter, and the catheter becomes less rigid, so more flexible, and you'll be able to advance it further inside the bile duct. The other thing that is important for stent placement, if the duodenum is patent, if there's no duodenal obstruction, because the data is mounting that duodenal obstruction will actually increase the risk of stent dysfunction or cholangitis. Even in patients where you create a gastroenterostomy, so the food is deviated from the stent, there will always be some juices, gastric juices, and food remnants that will actually go inside the bile duct and cause cholangitis. So if you look at data from Giuseppe Vanella and Paolo, the host of tonight, in the retrospective study, they showed that if you treat these patients with a EUS-guided gastroenterostomy, the choledochduodenstomy had a stent dysfunction rate of 31%. Comparing with transpapillary stenting, it was 18%, so also quite high. But hepatogastrostomy showed to be the most promising. They subsequently did a prospective series where the numbers are even a little bit higher, but it does seem that for these patients, hepatogastrostomy is a better drainage strategy. The other things you have to look for when you want to perform this procedure is if there's a tumor-free window. If you have the pre-procedural CT scan, you can already see that sometimes the tumor grows in too proximal of the common bile duct, and you will have to go through the tumor, and that's something that you obviously do not want to do. Sometimes there's ascites at the site of the planned trajectory, so don't try to go through it because the tip will lose all this electricity and you will not get into the bile duct. Sometimes you can maneuver and reposition the patient and you'll be able to go through. But in case of ascites, just remember to give a prolonged course of antibiotics. Make sure you visualize the cystic duct because sometimes it can be quite dilated. Make sure you don't place the stent in the cystic duct, which has already occurred sometimes. And remember that these patients may have portal vein thrombosis and have many collaterals. And you may be able to pass the stent catheter next to a vessel, but realize that the stent will actually expand and you might have corrosion of the vessel on the stent and get delayed bleeding. So most of us are currently using the freehand technique with the lumps, which is especially great when you have patients with a large diameter common bile duct, as you can see in this movie over here, where the common bile duct is actually larger in diameter than portal vein. That's always a good sign. And then you can slowly advance the stent catheter far enough and let the tip cool off a little bit and then start the deployment of the stent, which in this case, you can just do in one maneuver. You don't have to do it in a stepwise manner. So in patients where the bile duct is very slim, let's say it's below 14 or even 12 millimeters, then it may be wise to first puncture the bile duct with a needle, make a cholangiogram, and then advance the wire. In EUS-guided gastroenterostomy, going over the wire, introducing the stent over the wire is usually a really bad idea because you'll actually push away the small bowel, but the common bile duct is more rigid, and less flexible. So here it may actually help you. And for the really small diameter bile ducts, the lumps stent catheter may be too rigid as well, and the SEMs, so the self-expandable metal stents, may be more flexible and easier to introduce. So you can use those ones also for the small diameter bile ducts. So what can go wrong during the procedure? Well, a lot, but I'll only show you two variants. So sometimes you don't have an adequate view on your stent catheter, and here you can see that you actually hit the common bile duct wall because there are bubbles inside of the common bile duct, but there is no view on the stent catheter actually inside, so it probably bounced off here, which can also be due when you push in too hard. So too much pushing and not enough electrocautery. So to make sure you look for bile leakage, which will often occur to some extent, and bleeding, that you did not hit a vessel in your way of bouncing off the common bile duct. If there is not too much bile leakage, you could retry choledochduodenstomy. Probably better to first position a wire and then advance the stent, maybe then a more flexible SEMS over the wire. Or alternatively, depending on if this is your primary drainage strategy, you could actually go back to ERCP or even antegrade stenting, or ask our colleagues from the intervention radiologist to place a transpapillary stent and close the defect. The other problem is mostly related to the small diameter bile ducts. Here you can see on the top left a picture when you're unable to advance the stent catheter far enough in the common bile duct, which may result in the deployment of the distal flange in the wall of the common bile duct. And you may think you'll be able to rescue it, but usually it pops out in the wrong way. Like you see on the bottom left here, the stent is in between the common bile duct wall and the duodenal wall. And on fluoroscopy, you can clearly see it's outside the duct. So key is here, if this happens, try to get your wire inside the bile duct and try to pull out the stent through the scope. That's why it's very important not to deploy the distal flange. So it's quite easy to actually pull out the stent when only the distal flange is deployed. And then you can try to put either a SEMS back, for instance. What can go wrong after the procedure? It's mainly stent dysfunction. We have had a lot of problems with stent dysfunction, even up to the point that we were almost saying goodbye to this new technique. I know there's a lot of variation in the current literature about the rate of stent dysfunction, but in the studies that we've done, it's usually about 30% on average. That is, if you only place a lens without coaxial stent placement. Usually, this is the problem because of food impaction. Surgeons have tried this technique, choledochduodenstomy, already in the past, and they had so many food impactions that they actually switched to hepatogastrostomy with Roux-en-Y. So it's not an unexpected problem. And the other problem that we've been encountering is that when the bile duct is drained, that the contralateral wall of the bile duct will actually close off the fully covered lumps stent, as you can see here on this image. So for these reasons, we tried various strategies. Our latest paper was just published in GIE, where we tried to combine the best of both worlds. So we have the all-in-one stent catheter of the lumps, which allows you easy stent placement, and then try to reshape it with the SEMS. And it shows you then on the middle picture at the top that the direction of the lumen is also being redirected toward the duodenum. And if you look at the CT image, you can also appreciate that there's a larger barrier now between the food and the bile duct. So there's kind of a barrier coming. It, however, is a quite expensive and technically challenging procedure to do this. So it was more a proof of principle study. But in the meantime, there's also quite a lot of data. For instance, the Bumpy trial that has not been published, but the data was presented as the ESGE days, that stent dysfunction with plastic pigtails is reduced from about 30% without prophylactic coaxial stent placement to 10%. But this is at least how we do it currently, and with a good result, I have to say. So then we switch from the technical to the clinical part, when to do it. Most data that we have is in a palliative setting, or at least in patients that start off being with irresectable tumors. So in those patients, there's quite a lot of data, as Paolo said already, that there is high technical success and relatively low adverse event rates. For the choledochduodenstomy, there's been quite a lot of debate whether it's also safe to perform in preoperative biliary drainage. And the French group has also published data about this, and we have now a series coming up where we did a propensity score matching of choledochduodenstomy versus ERCP with SEMS. And the surgeons, we did a survey, and they told us that it had only minimal impact on the surgical plan that they had, and it had similar to potentially better post-operative outcomes. So even though the data is still limited, it seems actually to be a very good technique for this group of patients. So then, do we use CDS as a primary drainage or as a rescue strategy? Well, at least for the rescue strategy, we know there's quite a lot of data that it's at least as good as percutaneous approaches. So that's the recommendation of the ESGE. And we have two trials from this year from gastroenterology comparing between CDS and ERCP, although both were had negative outcomes for the primary endpoint, which was stent dysfunction, although I think in hindsight that may not have been the ideal primary outcome. Secondary outcomes did show that CDS had higher technical success and a shorter procedure time. I think there's a lot then can be discussed about these trials. I think the main point, what I took from it, if you compare it to the outcomes of ERCP-related complications we just published in Gut about patients with distal malignant biliary obstruction. In that study, we had high volume, but also a lot of moderate volume centers, and the post-ERCP complication rate was actually much higher. So up to 19% of pancreatitis and 6% cholecystitis. So it may, if you make the studies in a more real-world data group, that there may be more benefit of the EUS-guided approach. So in conclusion, CDS may be considered as a first line, especially in the palliative setting, because that's where we have the data, when patients are eligible. That means, is the bile duct sufficiently dilated? Is there no duodenal obstruction? So in a selected population, and if you have adequate expertise available. In resectable disease, it seems safe, and I think with this data you can discuss with the surgeons to perform it, but I think you should do this only in study purposes. The whole conclusion is also we need definitely better instruments and stents more suited for this procedure. So for the future, I think most of us will be working on to improve the stent design. We need to be able to place the stents also in smaller diameter bile ducts and further reduce the stent dysfunction rate. There's a lot of work to do for us to standardize our techniques and our adverse event rescue management and training. And of course, we need more data comparing it with ERCP. So thank you for your time already.
Thank you, Roy. Great talk. Questions are coming, but we are keeping questions for the end, to the end. So now I introduce Fabrice Caillol, who is the head of the endoscopy unit in the Institut Paoli Calmette, Marseille, France. He is going to talk about hepatogastrostomy, and everybody knows that hepatogastrostomy has been invented at the Institut Paoli Calmette. So thank you for joining us, Fabrice, and the podium is to you.
Thank you, Paolo, for the introduction. So my topic will be hepatogastrostomy. Hepatogastrostomy is performed in case of duodenal invasion or stenosis in 35% of the cases, in case of altered anatomy in 18% of the cases, and hilary stenosis in 16% of the cases in the literature described in recent meta-analysis in endoscopy. We have no data in case of failure of ERCP about the percentage down. Benign indication is rare, less than 1% for this indication. And we have a global morbidity of 12% and a high clinical success of 88%. This morbidity is maybe low, but US biliary drainage, in particularly hepatogastrostomy, can have severe adverse events. As you remind us, this drainage was created by Marc Giovannini in 2003 with a previous description of choledochduodenstomy. And from 2003, it is a bit the story of Marc with an increase of hepatogastrostomy in the unit and over the world. And as you see in this publication, the number of hepatogastrostomy increase over the years, and the number of adverse events remains stable over the years. So it means that we have less adverse events, the rate of adverse events decrease. And that's a good thing, probably mainly due because of dedicated device like partially covered stent or the use of CO2. But maybe we use some tricks and tips, and I will try to share with you some tips and tricks we have. The key point of hepatogastrostomy is the wire and its insertion in the bile duct. In a Spanish survey, you have a 28 failure on 41 patients due to the wire manipulation. So all our tips and tricks are focused on this wire utilization. Hepatogastrostomy has several steps. First, EUS view until the insertion of the wire, the key point, and begins then X-ray view. And at the end, you have an endoscopic view, but only at the end. All the procedure is under aspiration without the endoscopic screen, and just X-ray view at the end of the procedure to check you work well. You can puncture the segment 2 or the segment 3. Marc described first the segment 2, Japanese segment 3. In the literature, in the only publication, there's retrospective, there is no difference in terms of morbidity or efficiency. But please, if you perform hepatogastrostomy in segment 2, check you are not in the esophagus, because the drainage through the esophagus will be very inconvenient for the patient. It's a dramatic event with a pain and a morbidity very high. Key point of the puncture is very interesting because you have to puncture the cycle. Because behind the cycle, I think you see my mouse. Behind the cycle, you have the bile duct lying beyond the circle. So when you puncture it, you can easier insert your wire in the bile duct. If you puncture a bile duct, sorry, you see very well, you will puncture it perpendicularly, and you have not enough room, enough space to insert easily your wire. So when you choose your puncture site, you have to look for this circle. In segment 2 or in segment 3, it's the same image. It's a classical hepatogastrostomy. You have to see the circle. And if you puncture the cycle, you see on X-ray view, you are in the good direction. Your needle is a good direction of the bile duct, and you can easily insert your wire. You need space from your intrabiliary duct and your whole stomach. You need to have between 1 and 3 centimeters to avoid bile leakage and to have safety when you will release your stent with your partially covered, with the frontier, the limits of partially covered with covered stent, sorry, on uncovered stent must be in this part of the liver. So you can puncture easily this cycle, but sometimes it's difficult. You have an anatomy of the patient. You can do everything very well, but in this case, it's the same patient. You have the cycle in both images. But when we puncture this cycle, you will see on the video very quickly. I'm sorry, be look carefully, you will have like a kink, like a curve in the bile duct. And in this patient, we did not cross this kink with the wire. We never crossed it. And we had to puncture after this kink to have an easier hepatogastrostomy. Oh, sorry, it is the text, I forgot. Another trick, when you don't see very well the intrabiliary duct, and when you are not sure you are in the good direction, it's the angle of your needle. The angle of your needle is described by Ogura. Ogura describes a lot of tips and tricks in hepatogastrostomy. The angle must be inferior to 130 degrees to your scope. If your angle is less than 130 degrees, you are in good direction. If not, you are not in good direction. It will be difficult to insert your wire. So once your needle is in the intrabiliary duct, you have to check you are in. Of course, to check you are in, you have to opacify. But if you opacify not in the bile duct, you will have, we can call it a magma. And with the magma, it will be difficult to puncture again. So you can aspirate some bile here, and the advantage is you can have a bacteriology of your bile. You can see the air you inject before contrast product, but it's not so a good method because just after air you will have contrast, and you want to avoid contrast first. And another trick is to look when you move your needle in the bile duct. If the wall of your needle is moving with your needle, probably you are in good position and you can inject. Of course, we have some device, probably we don't have it in Europe. These devices are in Asia. But these devices are very promising with the use of 20 gauge needle, with the use of wire adapted to the 22 gauge needle. We have also orientated needle, and the firms are working on it, but we don't have this progress yet. Salvage technique exists, described also by Ogura. We use it for a few years, but Ogura described it very well. When you puncture your bile duct perpendicularly, so you are not in the good direction, sometimes your wire go in the wrong direction to the periphery of the liver and not to the hilum. So to find the good direction, you have to remove under US view your needle to be at the anterior part of the bile duct, and gently you will move your wall and your erector to change gently the position of your needle. You can use also an angulated wire to have the good position of the wire. To release your stent, I will describe only the partially covered stent. You must have the uncovered part in the liver and the covered part from the liver to the stomach. And which length of the stent in the liver and the stomach? Probably you must not have too long stent in the liver. There is a tendency to reintervention if the stent is too long in the liver, and in our experience, it can be very difficult for reintervention if your stent is too close of the hilum. We are sure you must have enough stent length in the stomach, because delayed migration is possible, and if you have delayed migration with enough stent in the stomach, you won't avoid delayed migration, but you will avoid consequences of your migration because your stent will remain in the stomach. We use a 10 millimeters diameter of the stent, but I'm not sure that's a good diameter of the stent. We use it because we use it in the main bile duct, but maybe, and Japanese does it, maybe we have to use 8 millimeters or maybe 6 millimeters diameter stent, because with a high diameter of the stent, you can induce inflammation of the bile duct, and maybe you can decrease your patency in the intrabiliary duct. But we have not data about it. When you release your stent, you must avoid to create a space between the liver and the stomach. To do that, you have to release your stent in the operative channel under X-ray with a gently traction. Because if you create a space in between the liver and the stomach, this space will increase, and so you will, as a result, you will have a delayed migration. So the release was described also by the same author in Japan. So you release your stent with a traction in the operative channel, and just when it's done, you use the endoscopic view to push your stent in the stomach. Be careful when you remove your olive. Be careful because your stent is not totally angled. So how do you know you have created a space between the liver and the stomach? Because you see a candy sign. This candy sign is because you have so created this space. Here, the first compression is when the stent is out of the liver. Here, the stent increase in size because it is in the space between the liver and stomach. And here, the space enter in the stomach. So you have two compression. It's like a candy. But why it is important to see it? Because you will have delayed migration. So to avoid consequences of the delayed migration, you have to add another stent to have a very long stent in the stomach. And so you won't have consequence of your delayed migration. Look, hepatogastrostomy sometimes have no complication. In this case, I will sum up what I said. You have it's a segment 2. You have the circle, you see here. You have to take your time to puncture your intrabiliary duct. Sometimes it's quite difficult. It's very dilated, and so, but we puncture just on the side of the intrabiliary duct. But at the end, we could succeed. And once you have punctured your intrabiliary duct in the circle, because you are in the circle, you are in the good direction of the bile duct, you hope so. And here on the scopy, you see you are in the good direction. So you can insert easily your wire without peeling it and without injury. And once you have inserted your wire, you will do exchange. Insert your cystostome, a 6 French cystostome, not a too big cystostome to avoid bile leakage. With a 10 French, you will have bile leakage. You needn't to delay it, or please do not delay it, because with dilation, you will add potential bile leakage. And the 6 French catheter is enough to place the stent here with traction with the bile duct in the bile duct. You have to push your wire as long as possible. Please, in the main bile duct if it's possible, or in the right liver if not. And when you release your stent, not too close of the hilum, gently in traction to pass the liver on the stomach to get the liver close to the stomach to avoid to create this space with, as a result, a potential delayed migration. And at the end, once your stent is released in the operative channel, you will use the endoscopic view. Oh, sorry, it's a text, I forgot. Okay, and my last video, and it's to show you that it's not so easy, that complication can be very, very severe. Here it was a difficult hepatogastrostomy with no real dilation of the intrabiliary duct with air, and you see the first puncture, a magma of a contrast product. So the second puncture is difficult. With experience, you can guess where is the bile duct. You have air here. So we succeed to puncture the bile duct, but now we are in the bile duct, we have to insert the wire. And it was difficult with a lot of manipulation of the wire. And with a lot of manipulation, with a lot of change of wire, because you can see on the X-ray a lot of piece of wire, but finally we can place the wire in the main bile duct. But we didn't see, we have peeled the wire was injured. And when we pass the 6 French cystostom, look at the wire in the main bile duct. The wire will cut the bile duct here, and we were in the peritoneum. It was a difficult issue. You see, with opacification, we check because we did not it was difficult to understand what happened, but you see on the video the peel wire. If it's happened, the important point is to drain your patient because a bile leakage can be managed. So we insert another wire, of course, not the same, another wire in the right liver to have you see, we are in the bile duct, so we can insert another wire, and we could drain the patient. Unfortunately, the wire did not cut only the wire, but cut also the cystic artery. The patient did an hemorrhagic shock in the recovery room. Now the patient is well, it was an endocrine tumor. I see her in consultation after 2 years. But it was a huge complication, a severe complication, and it can happen because of the wire. So in conclusion, performing hepatogastrostomy needs several steps. Most of the tricks aim at having an easy insertion of the wire in the bile duct. Preventing complications are mainly linked to the wire. So I repeat the same thing, but it's very important. The technique is not totally standardized yet, and device must be improved. That's obvious. A new challenge is probably coming because survival of the patient increasing, the patency of the stent must be improved also. The story began in 2001, is ongoing. At the end of the year, Marc Giovannini will be retired in 2 days. So I wish him a good retirement. Thank you very much.
Thank you very much, Fabrice, and for this comprehensive talk. I think that I need to see also Roy, because now we will start asking questions and answering questions. And first of all, my greetings to Marc Giovannini. I met Marc the first time in 1994, so we are very old, and his retirement is something very, very difficult to accept for us. Anyway, I think that you both have described 2 very difficult techniques and show us very nice data and videos how easy could be in expert hands. So first, I think that the first question that we need to answer is about training. So I think that there will be 2 different answers. So first of all, I will ask Roy. Roy, in your opinion, how many procedures you must perform to be confident and to be safe in performing choledochduodenstomy?
Yeah, it's a good question, also a challenging one because nobody really knows, of course. But I mean, how it's going now, I think most people start with pseudocyst drainage or pancreatic collection drainage with lumps. Being very comfortable with the stent, don't have to look on the stent how it works. Then you start doing more complicated procedures. But as I was trying to explain, choledochduodenstomy is, I mean, it's one technique, but if you have a wide bile duct, it's a very different procedure than when you have a bile duct that's only 12 millimeters. Then it's suddenly a very challenging procedure. So I would even say that, you know, once you have done, let's say, about 20 therapeutic EUS procedures, you can start with the large diameter bile ducts, but wait with the small diameter because it's just a different procedure.
Yeah, and Fabrice, I think that most of the audience think that hepatogastro is very, very difficult and complicated, and I think that we all know that in very expert hands it looks very easy, but when you try to do that, it's very challenging. So what's your thought about the training to perform hepatogastrostomy safely?
Thank you for this question. So we have indeed no data about that. Probably you must have performed a lot of ERCP, because if you failed ERCP, it's not the same story. And training with ERCP helps a lot in case of complication, helps a lot in management of hepatogastrostomy. And then you have several kinds of hepatogastrostomy. I show you two videos in segment 2 and segment 3 with a cycle you can see very well. In this case, hepatogastrostomy is for beginners, not for beginners, but it's the classical hepatogastrostomy you can do. If you haven't this image, it could be very difficult and need a lot of experience. I don't know how many hepatogastrostomy you have to do before to do it alone. Just for in the unit, maybe I think after 10 hepatogastrostomy, people are enough good. And this depends also of your numbers of hepatogastrostomy. If you do a hepatogastrostomy once every 2 months, it's more difficult. So you need to perform hepatogastrostomy regularly, even to learn.
Okay, great. We definitely agree with you. There are some technical questions that we need to answer. Roy, you told us that sometimes when the CBD is smaller, it's difficult to advance the hot axis, and then so you need to move to another stent, or the idea of another stent. Somebody is asking why not doing in all the situation with the SAMS stent, why you're using hot axis and so on. Can you address this?
Yeah, it's a very, very good question. That's of course how the procedure was performed before development of the axial stent. Problem is with most stents that there's a higher rate of stent migration. And if you have a stent migration after you just created the fistula, well, there is no fistula, you'll end up with a huge bile leaks. But there are some stents who have who are quite good, like the viable stent I think they're using in the United States, which has more of anchoring flaps. But yeah, the whole benefit of the all-in-one stent catheter, that you don't need any exchanges, and the lumen opposing effect of the stent makes it a very safe stent for the most dangerous part of the procedure.
Yeah, and one for you, Fabrice. Hepatogastrostomy is difficult difficult. You didn't mention if you work with the patient in prone position or supine position or left lateral decubitus. And the second is the risk of sharing of the guide wire while you're playing in the biliary tract. How you be able to to be safe in this situation.
Okay, thank you. The first question, we are working with an intubated patient on the back and prone position to see to have a better view of anatomy of the liver. And the second point is about the peeling of the wire. That was all the topics. That's a problem because as soon as you will use your wire in the needle, the risk of peeling it exists. So do not force, gently move your wire. If it's hard to move your wire, remove a bit your needle under EUS. It's because probably you are too deep in the bile duct and you are blocked in the posterior wall of the bile duct. So remove a bit your needle and try again to move your wire. But as you saw in the last video, it happens, and I didn't show you all my complications because I have no movies for all. But that's really an issue, this wire.
Yeah, and another question is which size of wire do you use?
35, 25, and in the literature it's Visiglad or Jaguar.
Okay, and Roy, for you, this is very interesting because we are used to perform this release, intra-channel release, but we have a question: are you sure that you are releasing the proximal flange intra-channel, and when you release everything out, that you are really into the duodenum with the proximal flange?
Well, I have to say with the choledochduodenstomy, it's not that much of an issue because the bile duct wall and the duodenal wall are really thin. So if you use a 6x8, usually you only have like 3 millimeters of duodenal and bile duct wall together. So you don't even have to pull very hard on the stent to already release the proximal flange inside the working channel. And if you then pull back your scope, it usually already comes out of your scope without you having to push it out.
Great. And another very interesting issue is the position of your scope when you perform this choledochduodenostomy. Particularly if you are dealing with a small CBD and you have decided to use the needle and the guide wire. So which position and why do you have this position?
So I think in most patients, the tip of the scope is already looking towards the liver hilum, which will give you the best access. So you don't want to get into the rendezvous position, which is also a bit harder in general. So in most patients, the tip will go upwards, and preferably you get your wire deep into the left hepatic duct, because then you probably have the most straight angle to advance your stent.
Yeah, and for you, Fabrice, if you don't, because you have cited the use of the 6 French cystotome, but in some countries they don't have the 6 French cystotome. So in this case, you suggest to avoid to perform hepatogastro or go for other devices?
Thank you for the question. I have no really answer because we use a 6 French cystostom, but in Japan they don't have it. They use dilation, they use a plastic stent, but they dilate very, very with a thin catheter and place their plastic stent. So it's possible. It's possible, but I think it's really easier with the 6-French cystostom. And it's another step to perform without it. But you must ask to people who do it without it. But I think it's safety. If we can speak about safety in hepatogastrostomy, but it is safety. It is a safety to use it.
Yeah, thank you. And there is always the debate about EUS guys and ERCP guys. I think that probably at the moment there should not be any more EUS or ERCP guys. But Roy and Fabrice, at this time in 2024, if you have a patient with a biliary stricture due to distal pancreatic cancer, would you recommend EUS-guided procedure, hepatogastro and choledochduodenstomy as a front procedure, or are you recommending ERCP at the moment as the first choice, with no obstruction of the duodenum, obviously? Roy.
So how we do it currently is that of course, we discuss with the patient first. But if the patient says do whatever you think is best, then we start with EUS, see if the bile duct is adequately dilated, your precision is good, there's no ascites, no collaterals. So if all looks good, we start with choledochduodenstomy. But if there's any doubt, not enough bile duct dilatation or whatever, then easily switch back to ERCP. That's our current approach. But it's also all in a study, of course. So it's like a registry, yeah.
Yeah, and in your team, Fabrice, do you prefer
ERCP first? We never perform US biliary drainage in first intention because we deeply think that adverse events are potentially more severe in case of US biliary drainage. And so we didn't stop to have ERCP in first intention, and but we are looking, we are watching guys who do it to see what will be the future.
Yeah, and in case of duodenal obstruction, this is a very interesting question. Do you prefer to perform first gastrointestinostomosis and then the drainage of the biliary tree, so whatever choledochduodenostomy or hepatogastrostomy, or you perform first the biliary drainage?
Who are you asking?
You have time, guys. Don't
Roy,
be shy.
please. Roy, please.
Okay, so let's assume the stenosis are both in the same time, right? So you have the patient.
Yeah, it is absolutely.
Okay, so well, I would start a procedure with a gastroenterostomy personally, and then if there's duodenal obstruction, we have the differentiation. I know it differs between centers, but if the patient would be resectable but have like therapy before chemotherapy, we would actually only go for transpapillary stenting, probably by the intervention radiologist, and only in case the tumor is, resectable, there are metastases, then we would go for hepatogastrostomy.
And you, Fabrice?
So in case of duodenal compression, we manage first the duodenal obstruction. Historically, because when you place a duodenal stent, you insufflate your stomach. So if you insufflate after hepatogastrostomy, you will increase your adverse events. So because we first placed a duodenal stent, we begin by a management of duodenal stenosis, but we do not do for each patient gastroenteroanastomosis. We continue also to place duodenal stent in some cases. We don't know exactly which indication are the good one, but so we didn't have really choose what exactly the indication. And first we perform hepaticogastrostomy. It's even if the patient is operable, but operable patient with double stenosis is not a common fact.
Another question for you, Fabrice,
is how can I say? Do you perform the hepaticogastrostomy in case on the tract of your needle you see liver metastasis?
If you, of course, if you opacify and you see you have another stenosis, you thought you have one stenosis in the main bile duct, for example, and you opacify, you have another stenosis because of a metastasis. That's an issue. It's rare, but that's an issue. The best thing is to not have this case, but if you have it, you can force the metastasis with a 6 French catheter. We did it, and you place a stent after the metastasis. But it's a potential big issue.
And looking to benign disease, do you use hepaticogastro or choledochduodenstomy to treat stones with lithotripsy in case of a complete failure of ERCP? Do you have that data? Do you have experience in this field?
I will begin because in case of altered anatomy, we have data about benign stenosis. We published 2 papers about calibration of benign stenosis for hepatico-jejunal anastomosis. It's working. We have, when we published the paper after 13 months, we did not have relapse. Now we have relapse after publication. For stone, we use it, but just in case of altered anatomy. In case of failure of ERCP, we repeat ERCP if papilla is accessible for benign stenosis.
Yeah. And Roy, and you mentioned about the dysfunction of the hot axios, which is quite high, 30%. And can you just tell us what you do in case of dysfunction of the hot axios? What's your favorite treatment?
Yes, so now we standardly use the double pigtail stent to the hot axia. So in case that one gets clogged, then what we do most of the time, we use the fistulous tract to place actually a transpapillary stent and take out the axials from the choledochduodenstomy, which will close by itself. And you can either, if you're still able to get in front of the papilla, and you can do like a rendezvous with yourself, so you use the axials as access and leave the wire via the papilla and the duodenum, and then maybe pick it up and cannulate the bile duct. Or sometimes when there's a duodenal obstruction, you can just use an antegrade stenting. So you take out the axials and you go via the bile duct and leave the stent there. But it's a little bit more challenging because the stent has to be above the stricture, but not through the fistulous tract again, right? Because then you can still have fluid impaction.
Okay, guys, thank you very much. I think the time has run out. Discussing with you, time is really running. And I think that probably in the next future, we need to perform another webinar discussing about the other possible drainage indication like anterograde stenting or rendezvous or gallbladder stenting to drain the biliary tree. But for now, thank you very much again for being with us, for sharing with me this webinar. I think it was a two great talks and with a lot of debate. And there are other questions on the Q&A, and I thank you all the audience for being so interactive with us. Then I just invite you for the next webinar, would be on Wednesday, December 4, Back to Basics, Part 5, Common Endoscopy, when and how to use. This will be very, very nice, another very, very nice webinar to be followed. And is very important. I want to remind you that the next ESG days will be in Barcelona. I think that everybody will be there because of Barcelona, but obviously because of the ESG days. And remember that the early registration deadline is February 10, 2025. And another very important thing that I want to remind you, particularly if you are young, talented ESG members, that the Next Generation Award 2025 edition is open for application. And if you are not that young, remember that there is a very new ESG Academy that is held by Mariana Varnikitakis and give the possibility to improve your skills in many, many different topics of the endoscopy. And finally, but very important for if you are young and endoscopists and want to find out your society, I think that you need absolutely, definitely to register and for ESG, because we are comprehensive for all European countries. So thank you very much again to our two outstanding speakers, and thanks to the ESG Governing Board for giving us the possibility to organize and to share this ESG webinar, and to the webinar team, David, Inker, and Vasoprifti, for their invaluable cooperation and help. Thank you very much, guys. See you very soon. Thank you again for being with us. Bye-bye.